I'd also like to welcome our panelists, Esther Pearl from the Alzheimer's Association and Dr. Jain from UCONN Medical. So here at McLean, we always want to be a resource for the community we serve. So tonight, we're talking about dementia and Alzheimer's, the most common form of dementia, which is certainly an isolating disease, as well as a leading health crisis in this country and around the world. We're hoping that this presentation tonight, we could look at where and how we could be a better resource for all of you. We want to elevate the conversation of dementia and try to eliminate some stigma that can still exist around this disease. We want to make a difference for people with dementia and their caregivers. But make no mistake, this is a tough diagnosis. But we're lucky enough to be here tonight all together to listen to this great panelists, learn, and support one another. So we're thrilled to welcome our two panelists here tonight and help us learn more about what happens after the diagnosis of dementia or Alzheimer's. I'll give each panelist more time to introduce themselves as they have their talk. And please join me in welcoming Dr. Jain, again from UCONN Geriatric Psychiatry, and Esther Pearl from the Alzheimer's Association. And I'm going to hand the mic over to Dr. Jain.
Thank you, Anne. It is a pleasure to be here this evening. My name is Neha Jain. I'm a geriatric psychiatrist. I work at UCONN Health. And let's see. I don't really have any disclosures that are relevant to our talk tonight. But what I do want to share with you is that I've always been fascinated with this idea just of getting older. That's kind of how I went into geriatrics. And I remember very clearly being 8 and asking my mom how old she was. And she said 40. And I remember thinking, wow, that's old. And as you can imagine, I am past that age now. But something has shifted. When I tell my kids that I'm old, they say, no, you're not, you're young. And then when I see my patients in clinic, and if they say they're 70 or 75 and they say they're old, I say, no, you're not, you're young. And the reason for that is not just that our perceptions of what's old has changed, but the fact that we are living longer. And even though it's hard to believe sometimes doing what I do, we are living healthier. The problem there, or the challenge there, is that dementias broadly are a disease of old age. So even though we are healthier, the more older we get and the more number of old people we get, the more of dementia that we see. So our goal today is to talk a little bit about dementia, talk a little bit about the types of dementia, because there's many different types and they're all very different. Talk about the treatments that are out there, talk about prognosis, talk a little bit about the resources and research, but I think for resources I'm going to leave that to Esther. So before I get going, very quickly, how many people in this room, and as long as you're comfortable sharing, how many people in this room have a memory issue themselves? How many people in the room are taking care of people with memory issues? How many people in the room are worried about memory issues? Okay, that's helpful for me. So, dementia is, first of all, not just memory. You know, the newer name, the fancy DSM-5 name for dementia, is a major neurocognitive disorder. And cognition is more than memory. It can be language, so the ability to read, the ability to write, the ability to comprehend a language. It can be the ability to perform a task, driving, cooking, following a recipe, balancing a checkbook. It can be the ability to recognize things, either by vision or by touch. And most importantly, executive function, which is exactly what it sounds like, the ability to plan and organize. And we do a lot of this. Okay, is this better? Yeah. Okay, sorry about that. So oh, you're sure this is better? Yes. Okay. planning and organizing, we do a lot of it without necessarily realizing, right? So you get up in the morning, you plan your clothes for the day. You plan what you're gonna take out of the fridge and have for breakfast. You plan your appointments for the day. First I'm gonna do this, and then this and this. Driving requires a huge amount of planning and organizing. And all of these things can be affected differently in different types of dementia. This is one of my favorite quotes from one of my favorite authors, Sir Terry Pratchett, who died in 2015 of a rare type of Alzheimer's dementia. And after the diagnosis, he wrote, "There isn't one kind of dementia. There aren't a dozen kinds. There are hundreds of thousands, and each person who lives with these diseases will be affected in uniquely destructive ways." And that is just something that stuck with me ever since. So, like we said, there isn't just one kind of dementia. It is an umbrella term, which includes many different subtypes, and we're going to talk about a lot of them today. The biggest one is actually Alzheimer's disease, so we'll talk about that. There is also vascular dementia. There is Lewy body dementia. There is frontotemporal dementia. And just in case this wasn't complicated enough, you can get two at the same time. So you can have Alzheimer's and vascular disease in the brain. And different types of dementia can present differently, they can progress differently, they are treated differently. That is why it's important to know how they are different. So we'll start with Alzheimer's disease. Another good quote by a good author: "Memory is the diary we all carry about with us, and when you don't have your diary or your phone or your calendar or whatever you use, life is hard." Who gets Alzheimer's dementia? I do think it's important to divide risk factors into what's fixed and what can be changed. So as we get older, our risk of getting Alzheimer's goes up. But that is a fixed factor. We can, but we don't want to. No, we will get older. Education is a protective factor. The more years of education you have, the more protected you are against Alzheimer's. But again, when you're going through school, when you're young, that's not what you're thinking about. So pretty much by the time you're older, that's a fixed factor. Family history, genetics. If you have had a family member, a blood relative with Alzheimer's disease, then that's a big risk factor. People with Down syndrome tend to get Alzheimer's disease as well. But then there are factors that can be changed. So things like smoking, alcohol use, high blood pressure, diabetes, hearing and vision loss, activity, all of these things that can be modified and can affect the risk of developing Alzheimer's disease. Now, thinking about the course of Alzheimer's, I think of it broadly as 5 stages. First is the preclinical stage, where there is nothing to see on the outside, but on the inside, in the brain, the disease process has started. And in this case, it's the clumping of a protein we call amyloid, or as I like to call it, gunk. So there is gunk in the brain, and you can see it, but you don't see any changes on the outside. Then there is a stage called mild cognitive impairment, which is becoming a real big focus these days in terms of treatments and research. And this is because this is the earliest clinical stage. This is the stage where there is an objective change in cognition, but it's not enough to be called a dementia. But there is some change that we can measure. Then we come to mild, moderate, late stages, and we're going to talk about all of these. So we used to see people usually at the stage of mild dementia. Now I will say we probably also see a lot of people at the mild cognitive impairment stage. But this is when things first come to light. And this looks like memory loss for recent things. So a classic example is, well, mom can remember everything that happened 20 years ago, but she can't remember what happened last week. Or we're having a conversation and she's asking the same question again and again and again in the course of the same conversation. Trouble with more complex tasks, so things like driving again, maybe balancing a checkbook, so things that are quite complicated, those becomes hard. There may be some changes in personality. What I see a lot is, because at this stage, a lot of times people still know. So So they know something is off, and that will often lead to anxiety. So we see a lot of anxiety about what's happening to them. We see some depression. We see trouble with, again, just organizing, expressing themselves. Again, misplacing simple things. And I don't want you all to think that, if you misplace something and found it the next day that you have mild dementia, because you don't. It is when you actually lose things. It is when you actually lose words. It is when you actually, and then they don't come back, right? They're just gone. At this stage, we'll talk about, there are things that we do in terms of treatment, and we'll talk about that in a little bit. Moderate dementia takes us another step further. This is, more difficulties with judgment. So this is where a lot of fights over driving happen. The family's like, you're not safe driving, and the person with dementia doesn't see that. Confusion in terms of, a classic example is, again, maybe living, a few years back. So it's 2024, the person with moderate dementia is living in 2019. So to 2019 and before, they're fine, but what's happened since then, they don't know. There may be some wandering in this case. Often it's because, again, they're 5 years back in their head, so they think it's time to get up and go to work. But they retired 5 years ago, but they don't remember that. So they get up and get dressed and they want to go to work. Or further along, they might think that their home is not their home because they've only been in this home for 5 years, and so they don't recognize it. They want to go back to their home where they lived for 35 years. More memory loss. Here is where the memory loss starts going from very recent memory to even memory far back. They may need help with simpler daily activities. So now we're talking about things like doing laundry. This is when the stove gets left on, or, dad can't make his favorite recipe anymore, even though he's made it all his life without a book. This is where they need help with going to the doctor, with managing their pills, things like that. More changes in personality and behavior. More than anxiety and depression, we start seeing just what I call psychosis, so delusions mostly. And again, think about that same misplacing of things. In the first stage, it was like, well, I misplaced something. Now it changes into, I've misplaced something, somebody took it. And who is it going to be? It's usually the person that's living in the house with them. So it's the spouse or the child or the caregiver, right? And we know it's not real most of the time because it doesn't make any sense to steal a hanger out of your mom's closet. Hallucinations are less common, but they can happen. That's when people are seeing things where things don't exist. But mostly we see a lot of delusions. Somebody broke into the house, somebody's stealing from me. If they have a spouse, thinking that their spouse is cheating on them. And so you can imagine these things are very, very distressful to the patients, but also to the family. Sundowning, or what used to be called sundowning, becoming more confused, more agitated, more restless during the afternoon and the evening. So that is where you start seeing more of the wandering, the wanting to leave the house, the getting very upset, the lashing out verbally or physically. And then finally, the later stages of severe dementia. This is where even the simpler tasks become really hard. So people may stop eating. They may not eat until food is put in front of them, or maybe even until they're fed. A lot of people will lose weight at this stage because they forget how to swallow. They become, movement is difficult. They may just sit in a chair, kind of sleeping off and on all day and all night. Pretty much requiring full assistance at this time. They may have trouble communicating their needs. So if they have pain, if they have discomfort, they may not be able to express that. And then that can sometimes feed into the agitation that you see. So they're upset, but they're upset because they're in pain, but they can't tell you. So starting from the very first stage, we used to say that from the time of diagnosis, the course of Alzheimer's disease is about 10 years. That has changed simply because, number one, we're diagnosing it earlier. Number two, again, people are living longer and becoming healthier. So it isn't unusual for people to survive 15 years, maybe even 20 years after the first diagnosis. When death happens, it is usually due to problems that are peripherally related to the diagnosis. So again, if they don't know how to swallow, they may swallow wrong and get a pneumonia. They're more prone to having falls and maybe having a fracture. They don't remember to drink anymore, so they're more likely to get dehydrated and go into organ failure. And those are the kind of things that lead to death. In terms of what you see in the brain, so this is a healthy brain on the right and an Alzheimer's brain on the left. You can see an overall shrinkage. If you squint from a distance, you can see that there is just less stuff on the left, right? Less brain matter. And the gaps, the black spaces are the gaps. The gaps are wider, there are more gaps, there's more empty space. And then specifically, these little pale pink dots here, this is the memory center, this is the hypothalamus. And you can see here, it's nice and full, and then it starts to shrink. Same, you can see things on a PET scan these days. We do that for some of the newer medications, where again, you can see a healthy brain has no amyloid, and in Alzheimer's disease, you see a lot of this gunk. The red stuff is all amyloid. Now, in terms of treatment, I really first want to say that there is no definitive cure for most types of dementias. There are very few dementias that we're not even going to talk about that are potentially reversible, things like a nutritional deficiency or depression that looks like dementia, but that's not what we're talking about today. Most dementias cannot be cured. That being said, there are a lot of treatments that can help, and that's what we're going to talk about. So first, there's medications. There is three broad categories of medications. The acetylcholinesterase inhibitors, these are medications that increase the level of acetylcholine, which is a chemical messenger in the brain. We start this at the very mild stage. The first time we see somebody that we think has a diagnosis, it can be started in any stage of dementia. And then you can add another medication called memantine, which works on a different chemical messenger that is supposed to actually harm the brain, and so it actually reduces the level of that damage. So you can use both at the same time. They do have side effects. They can cause, the biggest one that I think we stop it for is either stomach upset or slowing of heart rate. And again, a lot of people already have heart disease or they already have problems with their rhythm, so they can't tolerate further slowing of the heart rate. And even if they do take it, the efficacy is modest at best. What all of the research has shown that if these meds do work, they might increase the ability of a person to live independently, maybe for a couple of more years. So it's small, but it can be significant, and that's why we continue to use these medications. Then there is the newer, shiny, recently FDA-approved medications, lecanemab and donanemab. These are medications that actually target the gunk, that target the amyloid, and keep it from clumping in the brain. So they are currently approved both for mild cognitive impairment and mild dementia of Alzheimer's type. So only 2 stages of disease. Has to be Alzheimer's, either mild cognitive impairment or mild dementia. Lecanemab is every 2 weeks IV infusion. Donanemab is every 4-week IV infusion. They both have side effects, obviously infusion-related side effects, so things like fever, flu, nausea, vomiting, changes in blood pressure, headaches, things like that. More serious is what we call ARIA, which is, again, I don't like fancy words. Think of it this way. This is your brain, and I'm asking you to pass a message, let's say a football, from this corner of the room to this corner of the room, right? And you pass it to him, and he passes it to her, and we pass it along. Then I bring in a ton of junk, boxes and garbage bags and furniture, and I just pile it in between it and block the path. Now you can't pass the message as easily anymore. Then I bring in a snowblower, and I just push all that junk out of the way to clean up the spaces. Now I've cleaned up the spaces, but in the process I've digged the wall, and I've pulled some wallpaper down, and knocked some chairs over, and that's kind of what these meds do. They remove the amyloid, but in the process they can cause leakage in the brain. And that's what you see with the swelling and the small bleeds, and that's what we call ARIA. You can see in this picture, so there's like small bleeds, there are these tiny little holes. Most of the time this is minor. Most of the time there is nothing to do. To prevent it and to minimize it, we do a lot of things. We do regular MRIs when somebody is getting an infusion to track it to make sure they're tolerating the medication. We can also do genetic testing because there are certain kinds of genes that make people more likely to have ARIA. And as of now, at least at UCONN, people who are at the highest risk, we don't give them the infusion. Again, if somebody's on blood thinners, they're already at high risk, so there is a lot of that kind of stratifying the risk and deciding who this might be safe for. And then this is a big one. I think there is a very big role in all dementias for non-medication treatments. A big one is occupational therapy, which is simple functional therapy, right? So a particular task has become hard. How can I do it in an easier way? Fixing hearing and vision loss, we're getting more and more data that can go a long way. So again, if people have hearing loss, vision loss, improving that can make a significant improvement. Cognitive rehab, so again, focusing on particular, so if somebody has particular trouble with language, with word finding, they can work with a speech therapist to try to improve on that. And then a lot of things that people can do at home, structure and routine being the most important. So the more stable things are, the more routine things are, the more as expected things are, the better people do. So really trying to avoid lots of changes, lots of surprises, managing all the medical conditions, again, still managing the high blood pressure, the diabetes, the high cholesterol. And then a lot of what we do as psychiatrists is again, managing the psychological symptoms that come with this. So the depression, the anxiety, the psychosis, the sleep changes, the wandering, all of those things. All right, so that was a lot. We'll still keep going? Okay, so we'll talk about some other dementias. This one's my favorite, and I'll tell you why. So vascular dementia, again, as the name says, vascular changes in the brain. The most common vascular change that we all know of is when you have a stroke, right? So a blood vessel in the brain gets blocked, an area of the brain doesn't have a blood supply anymore, it dies. There can also be just bleeding in the brain that then leads to inflammation and death of tissue. There doesn't have to be a stroke. Sometimes, a lot of times, people can have mini strokes where they really have no symptoms on the outside. They don't get weak, they don't slur their speech, they don't fall over, their mouth doesn't turn to one side, but they are still having these silent, tiny strokes in the brain that over time can accumulate and cause damage. They may not even have a stroke, but their blood vessels are just getting thinner and thinner, and so the brain is not getting all the oxygen it needs. So everything that you can think of as bad for your heart in this case, everything that increases your risk of having a heart attack is everything that increases your risk of vascular dementia. So smoking, drinking, high cholesterol, high blood pressure, a sedentary lifestyle, atrial fibrillation if it's not controlled, all of those things increase the risk. And the reason I like vascular dementia is, as I was making this presentation, I was going online and I didn't want to put in stock pictures of just like happy people. So I was looking up famous people that we all might know that have had different types of dementia, and I couldn't find anybody that had a known diagnosis of vascular dementia, even though it's very, very, very common. And the reason for that is I think it isn't understood and publicized in the way that Alzheimer's is. And again, I feel very strongly about this because I think this is a risk in an area where we can actually make a lot of changes. We can actually significantly reduce people's risk without life-threatening, without big interventions, without any drastic measures. So what does vascular dementia looks like? It looks like as if you had a lot of tiny mini strokes in your brain. So more than memory, this is where people just slow down. They are unsteady, they can fall, they think more slowly, they talk more slowly, And you may think they're more impaired than an Alzheimer's patient, but then when you actually test their memory is sometimes not as bad. Of course, it will depend upon where that vascular insult in the brain is, right? If they've had a stroke, in a particular part of the brain, you're going to see those changes in their body as well. So it can vary. But this just looks very slow, very flat. And so we see apathy, which is what I call lack of motivation, lack of interest. So this is when, grandpa loves his grandkids, but now everybody gets together for the holidays and he just sits in the chair. He doesn't care. Or depression. A lot of depression comes with strokes in general, but also with vascular dementia. And unlike other depression, can be pretty hard to treat. The good news here is that this can be not treated, but prevented. And just like any prevention, this starts early. So you want people who are in their 40s, people who are in their 50s. Those are the people who are in their 60s. These are the people who need to control their blood pressure, control their cholesterol, reduce their risk of blood clots, control their diabetes, make sure they get some exercise every day. And that can make a big difference in prevention. And even if they are diagnosed with vascular dementia, it can make a big difference in them worsening. Because again, unlike Alzheimer's, which is sort of a slow and steady downhill course, vascular is directly related to the vascular insults. So it's more choppy. It's like, boom, you have an insult here, then you're fine, boom, another stroke, you drop down. So if we can prevent that second insult, we can still protect the brain. So managing the vascular risk factors very, very aggressively is a big deal, and that's why I like it. We do use some of the Alzheimer's medications. They do seem to help a little bit for some people, but a lot of this is, again, symptom-based. So if they're depressed, we treat the depression. If they are having psychosis, we treat the psychosis. All right, next is frontotemporal dementia. This is very different from the other two. It will often start very early. So when we think of Alzheimer's, we think of people in their 70s or 80s. Vascular, typically, again, older people. Frontotemporal dementia can start in the people's 60s or even late 50s. And it presents with really prominent changes in personality, behavior, and sometimes language. So a lot of times family members don't think that this is a dementia. They just think something's wrong with Uncle Joe, right? So he has suddenly become, he was always the nicest guy. Now you can't take him out in a restaurant because he makes inappropriate comments. Grandma never cursed her whole life. Now she just sits there and she's just, saying words she's never said. So a lot of disinhibition, because the brakes are the frontal part of our brain. And that's what's affected in FTD. So you don't have those brakes anymore, those brakes that tell you that something's a bad idea. So you see people doing those things. You can still see a lot of lack of motivation, just a lack of interest, lack of apathy. The temporal part, that's what leads to some of the compulsive symptoms. For a lot of people, there is a hyper focus on anything to do with the mouth. So whether it's just food, people will become obsessed with food, particularly sweets. Families will find themselves locking the pantry at night because they will just demolish everything sweet in there. Sometimes it's not even food. Sometimes it's just chewing on things, maybe even non-edible things like paper or plastic. So just a lot of focus around the mouth. And this is a function of the temporal lobe. The other one is that compulsion, kind of getting stuck in a repetitive pattern. So some of the examples I've seen over the last many, many decades is getting stuck on the toilet, for example. So you go to the toilet, you do your business, and then you just don't get up. And you're just sitting there for hours sometimes, unless somebody comes and physically drags you off. I had somebody else who would just sit there and cut plastic bottles into small pieces all day long, which, as far as compulsions go, wasn't terribly bad, right? How much damage can you do? Go ahead, cut the bottles. And that's the other thing that we focus on when it comes to management, is if there is a behavior that may be odd or unusual, is it truly harmful? Or is this something that can be safely ignored, right? So if you're stuck on the toilet for 2 hours, I'm gonna worry because when you get up, you're finally going to get dizzy and you may have a fall. But if you're sitting there cutting paper all day, fine, like just make sure your hands are okay, but that may be something that can be ignored. So the diagnosis, again, it's very obvious on the MRI. This is big enough. So you can see here, you see a very clear frontal atrophy. So you can see this is the nose, so this is the front of the brain. Again, a lot of blank space, very little brain matter. And then these are the eyeballs, this is where the ears are, so this is the temporal lobe. And again, you can see compared to the other side how much it's shrunk. So again, no good treatments. We treat what comes. If they are depressed, we treat that. If they have delusions, we treat that. A lot of times there's a lot of aggression that can become very, very hard. And if people are in the home, we do our best to treat that because we want to keep them in the home. But a lot of this is just environmental adaptation. So again, does something set them off? Is it possible to avoid that? Then just avoid it. They look at car keys and they get upset because they want to go on a drive. And they can't drive safely anymore. Well, take the keys off the wall. Don't show them the keys. Take the car away. Don't let them see the car. So removing things, and I know that's not always ideal and there's a lot of problems associated with that, but that's what we have to do sometimes. Again, maintaining structure, maintaining things as calm as possible, simplifying things. I see a lot of compulsions around using the bathroom for some reason. A lot of people with dementia hate taking showers. And families will struggle and suffer. And sometimes the conversation looks like, well, she really doesn't want to take a shower. I have to drag her, she's kicking, she's screaming, she bit me. I'm like, okay, how often are we taking a shower? Well, we try every day, but we probably get it every other day. Okay, does she need to take a shower every other day? It's January in Connecticut. She's going out once a month to see the doctor. Does it matter if she takes a shower once a week? So things that can be avoided, you avoid them. Delusions, a classic example, like, oh, I see this scary, well, not scary. If it's scary, we have to do something. But they see something that isn't there. Okay, does it bother them? No, well then let it be. We all have imaginary friends. So really thinking about what needs to be treated, what is actually problematic versus just trying to fix people back to normal. All right, we're almost done, I promise, 2 more. So there is, and these 2 are related. So there is dementia of Lewy body. How are we doing on time?
Good, we like to stop at maybe 7 or a little bit after, so give people time for questions.
Okay, so I know it's fast stop, so we're gonna, Lewy body dementia and Parkinson's disease dementia are both similar in that the brain looks similar. There are Lewy bodies, which is again another abnormal protein deposition where it shouldn't be in the brain. The difference is that in Parkinson's disease dementia, Parkinson's comes first. And people can have Parkinson's for years and decades before they start developing the cognitive problems. In Lewy body, unfortunately, it either starts with the dementia or the dementia and Parkinson's comes exactly at the same time. So we see a lot of very awful confusion. We see visual hallucinations here more than anything else. So often seeing people, seeing animals, often not scary, but just very, very prominent. A lot of sleep movement disturbances, so punching, kicking, talking in the sleep, changes in blood pressure, loss of bowel and bladder control. So this is a difficult one. And then the problem is, if people look confused and they look like they're having hallucinations, we typically think they have an infection. And if people get confused because of infection, we give them antipsychotics. In this case, if you give them antipsychotics, they actually get worse. So bad that this is actually a diagnostic criteria. You give them antipsychotics and they get much worse, that's Lewy body. So again, age, gender, family history, some risk factors. Diagnosis can be made both clinically and with imaging. We can use the Alzheimer's medications, we can use the Parkinson's medications. We do use medications for hallucinations where we have to. The problem is that Parkinson's medications and the hallucination medications work opposite each other. So you have to basically figure out what the bigger problem is and try not to create, a second problem while treating the first one. So this is Parkinson's disease dementia. Again, Parkinson's first, so the tremors, the slowing, the rigidity, and then much, much later, the cognitive changes. And again, treatment is very similar. This is just a nice little table showing you the differences. I don't think you need a revision. We're gonna skip that. I'm gonna talk a little bit about research. So lots of good research going on, both on medications as well as non-medication treatments. Lecanemab in particular, now using it for other stages of dementia, for using it in first-degree relatives of those who have Alzheimer's disease, how to reduce those terrible side effects that we talked about. Is there a way to avoid a brain scan and just do a blood test for amyloid so we can treat people with these drugs that target other proteins implicated in Alzheimer's, and then simpler things like better hearing aids. What happens if we treat hearing loss early and properly? What happens if we use computerized brain training early and properly? Things like that. Alzheimer's Association has a lot of active projects, and again, lots of different ways to get involved. I'm going to talk very quickly about what we do at UCONN. So we do have a multidisciplinary memory assessment program that I'm a part of. I'm a geriatric psychiatrist. I work with geriatricians there. They are usually the ones who make that first assessment, that first diagnosis. We have neurologists, we have radiologists, we have speech pathologists, and we all work as a team through every stage, both with the patient and the family. We do offer the amyloid therapy program, and I think there's some information there on the table. The latest offering is the GUIDE program, which provides assessment, support, respite, and community care coordination, which, as you can imagine, is very challenging for families and caregivers. The only caveat here is it only covers people who have traditional Medicare A and B, so that's the limitation there. We have a center on aging where there is a lot of clinical trials going on, lots of resources. If you're interested, you can go online and look at them, and it tells you where to apply, who to reach out to, and all of that. So thank you so much for your attention. I look forward to the Q&A. I will pass this to Esther.
Well, thank you so much for McLean having us here tonight and this wonderful presentation.
Hard to hear you.
You can't hear, can you hear me now?
Yes.
Okay. I am not a doctor. My name is Esther Pearl, and I am program director with the Connecticut chapter of the Alzheimer's Association. My journey, actually, before I do that, let's see. No, that's okay. I have this handy thing. Thank you. So just a little overview of what, really close. Okay, I'm sorry. I will do my best. If you can't hear me, just wave, and then we'll be good. So just a very quick overview tonight. I'm going to talk just a little bit about facts and figures. I'm going to talk about time, and why is time, when it comes to a diagnosis, so important. We'll talk about living your best life, living well after a diagnosis of Alzheimer's or another dementia. And we are going to talk a little bit about all the programs and services that we have available through the Alzheimer's Association. So how did I end up here? I still ask myself the same thing sometimes. My journey was quite different. I did not start thinking I was interested in this field when I was 8 years old. In fact, it was when my husband Mark was 56, and rather than spending our first wedding anniversary celebrating, we spent it going to Boston to receive a diagnosis of younger onset Alzheimer's. Mark was 56 years old. it threw me, at least, into a world that I really knew nothing about. I knew nothing about Alzheimer's, other than that it was progressive and that Mark was way too young to be living with something like this. I was wrong. Shortly after his diagnosis, by chance, I met somebody who worked for the Alzheimer's Association. I got some information. It took me a couple of years to be able to call and say, okay, I need some help. There are things happening that I don't understand. I don't get it. Why is he doing this? Why is he not doing that? And as soon as I made that call, we got involved in some support groups, a group both for Mark, for people living with the disease, and I was involved with a caregiver support group. Mark started going to the early stage social programming, which I'll talk a little bit more about later. And somebody said to me, and I will say this, I'll rephrase it a little bit, but she said to me, you know, Alzheimer's is a really awful way to meet some amazing people. And I hold that still to be very true to this day, to meet some amazing people. Yes, I was asked to speak at a fundraiser shortly after we got involved with the association. Really, I just shared my story. And honestly, that is the night that changed my life. Up until that point, I really felt very strongly that there was really nothing that I could do. I couldn't change the disease. I couldn't change Mark's future. But, you know, I could do our wills. We did that. We took care of our healthcare directives. But what else could we really do? But sharing my experience in a room full of people and seeing that, well, people were applauding, and I thought that was very nice. You know, I didn't make a fool of myself or anything. But then I noticed people were standing up and they were applauding. And I thought, oh, wow. But then I saw people crying. And that's what got me. And I thought, wow, why are they crying? I'm just telling them about my life. And in those moments, I realized that maybe there was something I could do. Maybe there was something I could say that would make a difference for people. And so here I am, almost 8 years later, working for the association, and I have the privilege and the honor every day of being able to bring this education, this information, and this support to people who are living with the disease and those who are caring for them. This picture was taken at the first walk to end Alzheimer's that we went to. Anybody here been to a walk? A few people? Okay. So for those of you who have been, you'll know that, well, my favorite part of the day is the Promise Garden ceremony. At the beginning of the walk, everybody who's there has these colored flowers with different colors representing different connections to the disease. In this case, you can see Mark is holding a blue flower, which is for people living with the disease. Yellow is if you're caring for someone, orange if you're committed to our vision of a world without Alzheimer's and other dementia, and purple if you've lost somebody to the disease. So we have one person represent each color, stand on the stage, we introduce them to the crowd, and they hold their flower up high. And then everybody with that color flower raises their flowers up as well. Mark's daughter took this picture from in front of the stage, and I know without a doubt that in this moment, Mark knew that he was not alone. He knew he was surrounded by other people who were there in support of him and everybody else living with the disease and everybody caring for them. So this was really an amazing introduction to the world of Alzheimer's for me and for my family. So very quickly, a couple of facts and figures. Every year we come out with new numbers. And so this year, we know that there are almost 80,000 people in Connecticut living with Alzheimer's who have been diagnosed and who are over the age of 65. It's just how the numbers get reported, okay? To put that in perspective, the population of Simsbury and West Hartford combined is about 80,000 people. In Connecticut, we have close to 130,000 caregivers for people living with Alzheimer's and dementia. That's the population of Simsbury, West Hartford, Avon, and Farmington. is about 140,000, so a little bit more. And I looked up these numbers yesterday when I put this together for you. Oops. Caregivers with chronic health conditions, 64%. Caregivers with depression, about 28%. That does not surprise me. In fact, I would think it's a lot higher than that. Okay, let's look at some national numbers. Nearly 7 million Americans are living with Alzheimer's disease. Again, diagnosed and over the age of 65. 1 in 3 seniors dies with Alzheimer's or another dementia. And 70% of caregivers feel stressed when coordinating care. Does that surprise anybody? Another interesting statistic. 7 in 10 people reported that if their doctor thought there was something going on with their memory, they would want the doctor to say something. However, only 4 in 10 will say something to their doctor if they think they're having a concern, if they think they have some memory loss. That's a big difference. So we have to have these conversations. We have to be able to talk about it. What's important about time when you have a diagnosis of Alzheimer's? We talked a few minutes ago about some of the medications and the diagnostic process. These new medications that can help slow the progression of the disease only work in people in the early stages. So what does that mean about getting a diagnosis? Can we ignore the symptoms? Can we think, oh, they'll just go away? Can we think this is just normal aging? No, we have to take concerns very seriously, and we have to be the ones that are willing to bring it up to the doctors, because the doctors are clearly not bringing it up more often than not. This is an era of treatment. The treatments that we have are the ones that have to be administered in the early stages. So therefore, getting an early diagnosis is critical. The sooner somebody is diagnosed, the sooner they can educate themselves, and the sooner their family members can become educated about what they're facing. We just heard about many of the different types of dementias, many of the different forms of dementia, the different causes, and you could hear the different symptoms. So different symptoms, different care, different understanding, different knowledge, and different treatments for different symptoms. So having an accurate diagnosis is really important. We want to make sure that we can live well with the disease. Let's understand it and let's talk about it. Let's educate ourselves, let's educate our families, our neighbors, our friends, and let's educate our communities. You want to make sure that if you're facing a diagnosis, you put together a care team. What is a care team? It's anybody and everybody who's a part of your life. There is a role for everybody. I so often hear people say, well, my mom's caregiver, or my dad's caregiver, or, you know, I live 1,000 miles away, there's not much I can do from here. I don't say, sure there is. There's lots of things. We have technology now that there's lots of things that everybody can do. There's a role for everybody who wants to be a part of it. We talked a little bit ago about clinical trials. We live in a state where the Alzheimer's Association is currently funding more than $1.5 million for researchers right here in Connecticut, including at UCONN and at Yale. I happen to participate in a couple of studies. I'm fortunate enough to be connected to 2 studies down at Yale. Every 2 years I go and I get all those neuropsych testings, you know, draw the clock, draw the squares, what are those 3 words I said to you? Tried really, really hard here. One of the studies, I get an MRI every 2 years. I'm a healthy brain apparently, so I'm sort of a control. I figure for me to give 1 day every 2 years to maybe help find some answers to these diseases, how can we cure them? How can we prevent them? What more can we understand? I'm willing to give a day of my life every 2 years to be involved with that. And there are many studies, like mine is not a medication study. You know, sometimes people hear study and think, well, I'm not gonna take a medication. I don't wanna be that kind of participant. You don't have to be. There are so many studies that are out there. There's studies that are online. There's studies that are virtual. Some are on the phone. There's another one I participate in 4 times a year. I log into a portal and I play card games. You turn a card over. Have you seen this card before? Is this the same as the one before? And it flips over and I'm like, darn, I thought I got it right this time. 4 times a year, it takes about 20 minutes. I can do that. Again, healthy brain, just monitoring different recall and things like that over time. It's really not a big deal. It's just a little thing that I can do to try to make a difference. We also talked earlier about lifestyle interventions. I do have a handout over on the table here about 10 healthy habits for your brain. Planning for your future. How many people here have already taken care of their wills, their healthcare directives, all that kind of stuff? Most people? Okay. Let me ask you, at what age should you get all those documents in order? What would you say?
Now.
40, 60 now?
When you have children.
When you have children? How about this? How about age 18? Why?
You're adult.
At age 18, you're an adult. What happens if an 18-year-old has to go to the hospital? Do they have to call parents? Do parents have access to their young adults' healthcare information if they're not on the HIPAA forms? Who gets to make decisions about their medical care if they're not able to?
The 18-year-old.
Well, if they're not able to, who gets to make the decisions if they don't have documents in place? Just like if there's a 60-year-old or an 80-year-old that doesn't have their documents in place, who makes their decisions? Not necessarily the spouse, not necessarily the children, depends. I'm not a lawyer. But anyway, if you have children or grandchildren or great-grandchildren who are turning 18, in fact, I'll just share this one thing. We had a family a couple years ago who had shared with me the holidays were coming up, and you know, every year they struggled with what are we gonna get everybody? Nobody needs anything, nobody likes what other people buy them. So what they did is, as a family, all of the adults took care of their legal and financial affairs. And that was their gift to each other that year for the holidays. And I thought, you know, that's probably the best one I've ever heard, right? What a gift that is. If you've ever been in a situation where you needed to have those documents, and you say, thank goodness I had that all taken care of, or my loved one or somebody I know had all those documents in place, it's the best gift you can give somebody. And also having your voices heard. There are things that we experience either as people diagnosed or as caregivers that we wish we could change, that we wish people knew about. You have a voice. Each and every one of us has a voice. And I encourage you to find your voice and use it for good. I've had the privilege, and I think, you know, I've had a lot of experiences on this journey of mine. And I think some of the most impactful ones have been through my experience as a caregiver. I have spoken at the state capitol. I'll tell you about that sometime, and I think it takes a glass of wine to really share that one. But one of the more impactful experiences I've had was being able to sit at a round table with Chris Murphy. Anybody know Chris Murphy? Okay, pretty well-known name. And I shared with him some of the recent experiences I had at that time as we filed for Medicaid for my husband, which meant he had no assets, not a penny to his name. And I shared with him just some of the things that I experienced as a working professional. I was in my 40s at the time. We had gone through all of Mark's retirement money. I had to liquidate half of my retirement money. I had to pay taxes on that money that I had to liquidate. And I was not 59 and a half years old yet. So guess what? 10% penalty. And I said all this, just, you know, kind of I think something needs to be done about this. And Chris Murphy sat there 20 feet away from me. He put his pen down. He said, wait a minute, let me ask you something. He said, aren't there any exceptions for this kind of situation? And I said, no, sir, they're not. I can't do anything about that, but you can. And then, of course, I said, did I really just say that to a sitting U.S. Senator? You know what? I sure did, because that's what he was there for. Okay, I have a couple quick videos I want to play.
Did he do anything about it?
As far as I know, that particular issue has not changed, but there have been some changes through the Older Americans Act that now allows people under the age of 65 to access certain programs that were not available to them before. So, there have been changes. All right, let me see how I can get this.
I always
Not
have
showing, is it?
considered myself a really fiercely independent woman, and
Okay.
I found out that it's okay.
That's not working. So let's just go back.
I think accepting a diagnosis is a process, and everybody faces that differently. But for me, I have to mourn my
Oh, that's good, okay. Sorry about that. Technology is not my friend. So there were people who were talking about accepting a diagnosis, and it can be very challenging. And there's a process that many people go through. There are lots of people who may go home and close those curtains and sit behind the curtains in the dark for a while. And then they come to terms with the diagnosis. And then day by day, they start to open the curtains a little bit more and understand that there are ways to live well after a diagnosis. There are people who take up new hobbies, who experience things that they never did before. I tell you, Mark's diagnosis put us into high gear to attack some of those bucket list items. And I'm blessed that, at least at the beginning, there were some things that we were able to do. We were able to do that before Medicaid. But for people who have been diagnosed, I think some of the keys are to learn to ask for help. It's okay. There's no shame in asking for help, and there's no shame in accepting help. There are people that want to help. And I think it's really important for people to share their wishes now. It can be hard. These conversations, what do we want in the future? How do we want things to go? What do I want to have a say in? They're really, really challenging conversations. It's hard to think about it yourself. It's hard to bring it up with other people. It's hard to just address it. But at the end of the day, let me ask you, do you want to have a say in how the rest of your life goes? Or do you want someone else to make the decision for you? If you want to have a say, then it's critical that you get it written down and shared with other people. I will share this. When Mark was at the end of his life, we had the documents, we had his living will. There were some family issues, I won't go into all that tonight, but there were some family dynamics. Let's just say I was not the favorite person in the room. That's okay, I can live with that. But one of the things we did is we had the doctor, not me, we had the doctor pull out the living will. And everybody around the table read it. And they knew very clearly what Mark's wishes were. It wasn't about me. It wasn't, what I thought he wanted or what they thought he wanted. These were Mark's words, what he wanted. And I can guarantee you, each and every one of them were respected and followed because that's what he wanted. So I felt very happy that we had those hard conversations and that we took care of those things. As a care partner, if you're caring for someone who's been diagnosed, I'm going to give a little advice here. Educate yourself as much as you can. The more you know, the more you understand, the better care you can provide, and the better support system you can be to your loved one. Same thing I said to people who have been diagnosed. Learn to ask for help. It's okay to ask for help. It is not a sign of weakness. And maybe even harder is to learn to accept the help. Again, there's no shame in accepting that help. People want to help. You never know where the help is going to come from. There were people that I thought for sure would be lining up outside the door to help. And guess what? Not in sight. And then there were people that I didn't even know who lined up outside that door to help. And I remember having to call Mark's pastor and saying, this woman offered to come over and do some gardening with him every week, but I don't know her. Do you think it's a good idea? And I was assured it was good, and that was one of the best experiences that Mark had. And there were people that we just didn't even know. But I vetted them. I made sure they were okay, to come and help out. I want to just very briefly share a couple of slides from our website, because our website is full of information and resources for people who have been diagnosed, people who are concerned, people who just want to learn, people who are caring for someone. There are sections for caregivers. Everything from research, learning about treatments, learning about the disease, help and support. There's information for people diagnosed to understand what the disease is, how it may impact you. I said that there are some people who will go home and close the curtains and then maybe find their way out. There's some that just don't. But there are also a lot of people who may feel a sense of relief and say, you know what, now I understand why this is happening. Now I know why I'm having trouble. One of the difficulties, and this is sort of the flip side, one of the difficulties of the disease is as it progresses, people lose the ability to see how they're being impacted by the disease. So it's kind of this double-edged sword. But when people are aware in those earlier stages, there's often a sense of relief, like, oh, okay, now I understand why I forget this, or why I'm getting lost, or why I do this and don't do that. More resources, again, for everybody, anybody and everybody. And I want to talk just for a minute about a special group of programs that we have. So a number of years ago, somebody had called our vice president and said, what do you have for me? I was recently diagnosed and I want to be with other people. I want to be with other people who have a similar diagnosis, who are on this path. I don't want to be isolated. There must be other people out there. And we didn't really have anything at that point. But Carolyn got some people together and said, okay, let's have a group for you. You're important, you're an important part of this equation here. What do you want to call yourselves? And they said, we want to give Alzheimer's purpose. So they're known as the GAP group, Giving Alzheimer's Purpose. We have an incredible program set up throughout the state. We have some programs that are in person, some that are virtual, including a wonderful program right here at McLean and Simsbury that Ian, I'm sure, will talk about in a few minutes. But being with other people, it's that support group. And I can tell you the number of times I've gone on outings. We took a group to New York City to go see Carole King on Broadway. Long story, but it was wonderful. One of the best days of my life, being able to escort everybody around. But we have museum programs, their monthly outings, really fun things. I have the best job in the world. I really do. A little more information about the Alzheimer's Association. We are always looking for volunteers who are volunteer driven. So whether it's somebody who has an hour once a year to help out at a walk, or who wants to get involved in being a support group leader, community educator, or anything in between. We always have a need for volunteers. We have advocates. You know, I talked a little bit about speaking at the Capitol or with Chris Murphy. But even locally, writing letters to the editor, that's, you know, a huge part of what some of our advocates do. Trial match, I talked a little bit about some of the research trials. I have more information on that for you as well. Walk to End Alzheimer's. I do have a flyer over at the table. We are in the middle of walk season right now. We started with our first of 6 here in Connecticut last Saturday. We have 2 this weekend, and then 2 more coming up over the next couple of weeks, including East Hartford, Rentschler Field, on November 9th. I have a postcard over on the table about our early stage, our GAP programs as well, and a flyer, which you're welcome to take, with all of the resources, everything from the support groups to the 24-hour helpline. And I just want to make sure you know that all of our services are free and confidential. We don't charge anything for any of these, not a penny. And we can do that because of the generosity of organizations and individuals throughout the country, particularly through our walks. I'm going to stop. We're trying to be conscious here.
Thank you so much, Dr. Jain, and thank you so much, Esther, for sharing so much great information. So before we get to our Q&A, I just want to take a moment to share with you the programming that we have here at McLean. Some of the program we're having is what we're doing right now tonight, is the educational programming that we offer to the greater community, including our community here on campus. We also offer a day program up at the health center. A day program, it's a social model day program that we offer here that runs Monday through Friday, 9 to 3 o'clock in the afternoon. And it's a great program, it's a great respite opportunity for caregivers, and a great opportunity for people with dementia to come and spend the day doing activities together as a group. So that's a well-attended program and a great offering that we're happy to still be able to offer. A lot of those programs during COVID went by the wayside, so we're very happy to still be offering that day program here and now. As Esther mentioned, we have a community cafe that we offer through the grant of the Alzheimer's Association that we offer here at McLean, and that is offered once a month. That's the 3rd Wednesday of the month. We offer a community cafe. So that's for people with dementia and their caregiver who come, and we just have lunch together. We share stories, we share resources, we laugh, we cry, and it's nice to gather together people on the same journey. So we offer that here at McLean Community Cafe, and that's actually here in Goodrich that we offer that. We also do a caregiver support group. So that is an awesome program that we've been doing for many years. It's very well attended. I see some people in the audience here from our caregiver support group. Again, it's sharing our journey, sharing our stories, sharing tears, and sharing laughters and resource. So, and we offer that in person with a virtual option that some people can't, whether they can't come because they can't get somebody to watch their loved one, or they have work or whatnot. So that's a virtual and in-person option. So that's another great offering that we have. And that's the 2nd Friday of the month. I think most of the flyers are over here to my right that have all this information for you. We also, at the health center, we offer family dementia education. For people who are at the health center and their families that are there, we offer twice a year, we offer family dementia education, so we're proud to be able to offer that as well. Obviously, we offer some residential memory care at the health center on our Atwater neighborhood. So we're proud to say our Atwater neighborhood is a purple flag neighborhood, and that means that that designation means that we have best practices in dementia care. We're actually the first facility ever to receive that distinction, and we have been the first facility to ever be reaccredited with that distinction. That program is done in conjunction with the Alzheimer's Association and Connecticut Association of Assisted Living, so we're very proud of that.